And joining me from the University of Virginia, Dr. Richard Santen. Dr. Santen, hello.
Good morning.
Hello. Thank you so much for your time today. For myself and for the listeners at home, could you tell us a bit about yourself, some of your academic professional background, and what brings us here today?
Yeah, so I'm a reproductive endocrinologist. I've trained to study patients who have problems with estrogen and male hormone. Because of this, I've studied contraceptives as well. I've had a rather varied career. My first faculty position was at Penn State University in Pennsylvania. I became chair of medicine at Wayne State University in Detroit, and over the last 20 years have been at the University of Virginia in Charlottesville, Virginia. My interest recently has been to think a little bit about the long-term strategy of dealing with unwanted pregnancies. Now, how did I come to want to do that? So I was the president of the Endocrine Society, which is an 18,000-member international organization. One of the former vice presidents contacted me and asked me to share with her an opinion piece about abortion that the Endocrine Society would then publish. And I really thought that rather than the issue being the short-term concerns about abortion, the real issues are the long-term issues of how to deal with unwanted pregnancy. So that led me to review a lot of literature about unwanted pregnancy and about contraceptives. After this, I was asked by one of Dr. Carolyn Becker, she was the vice president, I was asked to give a college course on one session on this topic. So it was quite a labor of love to try to go back even as far as the Roman Empire to see what people thought about abortion. And I framed some views that I think are reasonably rational and are not really based on the controversies about the morality of abortion, but more about the practical issues. The last part of this is that my first mentor, Dr. C. Wayne Barden, became the chairman of the International Contraception Research Committee internationally, and he developed the contraceptive implant. This is the hormonal implant that lasts 10 years and was really a breakthrough for development of contraception in developing countries. So that's really the background of how I got interested in this topic and have tried to become scholarly in my assessment of what's going on at this point.
Now, to make things contemporary, to put a little bit of time-bound perspective on our conversation today, would you say that there is anything that has changed globally, nationally, even domestically, about attitudes and management of unwanted pregnancies and hormonal care generally in the last, say, 10, 15 years compared to any other trends or attitudes that you've seen over the course of your career in medicine?
I have to focus more on the United States. And it's quite interesting that back in 2005, Hillary Clinton was quoted in the New York Times saying that if we used contraception more effectively and more widely, that abortions would become relatively rare. And that was the thinking at that time when the Constitution of the United States said that abortion was a right for women up to about the second trimester. But in the last few months, since the Dobbs decision and Roe versus Wade was counteracted by the Supreme Court, the focus now has been exclusively on the issue of abortion, the morality of abortion, which states should approve it, and so on. So the discussion in the United States has been totally away from the whole issue of abortion. Now, if we go back several years, I think there have been so many different advances in the whole area of contraception that this has become or has been a major topic. And one of the most recent ones, of course, is the ability to have contraceptive pills for men which still is a major discussion in the literature. But of course, every time an article is written, it says that we're 10 years away from having a contraception pill for men, and each 10 years the same system. So I would say that over the last 10 or 15 years, there's been a lot of discussion about contraception, but this has really been superseded now by the focus on the whole issue of abortion.
And to kind of briefly put that in a global context, what does the prevalence of unintended pregnancy in the US globally, and then we could get into some of the access to contraception and how that differs on a national basis as well.
Yeah, so let's talk a little bit about that. So first of all, how do you define an unintended pregnancy? And this is either that you really don't want a pregnancy at all, or the pregnancy is too early and you would like to plan your family later. So that's what we're talking about. Globally, in the last period of time that we have data from 2015 to 2019, there were 120 million unintended pregnancies globally. That really surprised me. That's a huge number. And it turns out that if you compare high-income countries and low-income countries, there's quite a big difference. So let's talk about the overall incidence of unintended pregnancies. It's 64 women out of 1,000, ages 15 to 49. But if you talk about low-income countries, that's 95 per 1,000. And if you talk about high-income countries, it's 30 per 1,000. And this really says a lot about socioeconomic factors, financial factors, and healthcare factors. Now, it turns out that of those 121 million unintended pregnancies, about 50% were ended by induced abortion. And the number or the percentage of induced abortion has gone up over the last 30 years from 51% of unintended pregnancies to 61%. So it really focuses on the fact that the application of contraception to reduce unintended pregnancies has not really kept up with the level of science that's been there. I think that influential individuals who have expertise in this field probably need to work assiduously trying to write scientific articles that go over the science of this and apply the science to the practical applications, ultimately, of contraception. Often, this then gets the attention of the media when some of this information is written in influential journals. So I'm kind of looking ahead to trying to put together some of these concepts, all of which are exceedingly complicated, in ways that would frame this on a scientific basis. It's quite interesting when we look at the COVID-19 educational rollout in the United States that Dr. Anthony Fauci always talks about, let's follow the science. That's what he says in every talk that he gives. He's had a lot of pushback by the politicians saying that he has an attitude. But when you look at all of this over time, we have done an amazing job in developing vaccines for COVID, and people have taken it up and so on. So people really have followed the science. So I think this is something that is a strategy that one needs to focus a little bit more on the overall aspect of contraception and not the individual risks and benefits of the individual components of it. Everyone is worried about using hormones for menopause, and they say that there's a 30% increased risk of breast cancer if you take hormones. What that is relative risk. So it means that if there's a very small risk of breast cancer in the population, a 30% increase is a very small number of patients. If you fly round trip from New York to Paris, there's about a 1 in 10 million chance that you'll crash. If you fly on 5 round trips, there's a 5 in 10 million chance. That's a 500% increase in risk. That's relative risk. The absolute risk is only 4 in 10 million. So, as we talk about the risks and benefits of contraception, the newspaper likes to talk about relative risk. Even recently, talking about progesterone only contraceptives in premenopausal women, there is an increased risk, about 30%. But the absolute risk is minuscule when one really talks about the actual numbers affected.
Yeah, going from 1%, it's not up to 30, it's going from 1 to 1.3.
That's correct. But it depends on what the underlying risk is. So if the underlying risk is exceedingly small, any increased relative risk is almost meaningless.
And when we talk about contraceptive techniques that are available, are we strictly talking about hormonal interventions, things like the pill or the implant here, or are we including barrier methods?
So really when you think about it, this is really a complicated topic because there's so many different methods of contraception now. And of course, we all know about the birth control pill, which was developed in the 60s, and that's hormonal contraception. The implant is another way of hormonal contraception, which involves putting a silastic rod under the skin. Probably the more recent development is the morning after pill. This doesn't cause abortion. It basically causes prevention of pregnancy. And there are several different methods for morning after pills, but they can be taken for up to a couple or even 3 days after intercourse to prevent pregnancy. It's interesting that the copper intrauterine device, which works for a long period of time and is quite safe, if that's put in right after intercourse, that's also a method for both morning after, but also long term. One of the other recent developments is to use intrauterine devices that have the hormone progesterone included. These last up to about 5 years and are quite effective and without a lot of side effects. So we've talked about hormonal contraception. We talk about copper and some devices like that. Surgical contraception, of course, where we tie the tubes in a woman, or we tie the tubes in a man, or another method, we usually call it vasectomy.
Reversible or non-reversible?
They're both non-reversible. One of the things that's interesting about tying the tubes in men is something called scalpel-free tubal ligation. What they do is they basically just stick a needle around the tubes in the scrotum, insert something to dilate that, and then they can tie off the tubes and prevent pregnancy very simply. It takes about 5 minutes. And then finally, we have barrier contraception. And of course, mainly this would be a diaphragm in a woman or a condom in a male. And I think when we talk about that, this is something that requires some planning prior to the time of intercourse and is not so helpful for most people. But it's very important in countries that have a high incidence of sexually transmitted diseases. Then finally, there's something that many people would call Catholic roulette or Russian roulette, and this is the family planning method to avoid intercourse at the time of major possibility of pregnancy. And there have been some developments there too, because now we have a method of testing the urine to determine just when ovulation occurs. So I think you can understand from what I've said that number one, this is pretty complicated. Number two, there's been a huge advance in science in the last 30 years, primarily for hormonal contraception, but also for the intrauterine devices and the copper-containing devices. And of course, one of the problems with this is that it's so complicated that many general physicians or even gynecologists don't have a complete understanding of all of the different techniques that are available.
Well, to come back to something that you mentioned in terms of the long-term versus short-term solutions, that the implant could be a long-term solution, that the implanted IUD could be a short-term solution for morning after and kind of family planning. I've got it written down here that it's not an exact quote, that the most manageable pregnancy is the one that you don't have in the first place. And that seems to be the ongoing thrust of the literature that you're citing, and what you're trying to communicate here is that having kind of the best foot forward before conception is even on the table is ideally the right way to be managing family planning and medical planning and legal and moral planning, to just start off from that kind of position. Is that equally a professional position that you can start off with family planning well ahead of actually getting to planning a family?
So it's quite interesting that Mrs. Sanger, back in the early days, was talking about birth control as a way of preventing pregnancy because it was safer to do that than the complications of a pregnancy. And this led basically to the Planned Parenthood clinics. And the Planned Parenthood clinics really were originally designed for contraception, but of course later had a major focus on abortion. So if you look into the literature, this whole idea that we now have the ability to control the whole reproductive process in pregnancy has been an advancement of science, and it really is a better way to deal with the whole issue of unintended pregnancies. And particularly, the contraceptive techniques are really safer, in fact, than pregnancy. And of course, this depends really on what country you live in. So if you tend to be an individual in a country that's very low income and they're very poor resources, the maternal mortality rate is quite high. In areas that are very high income and high education, the mortality is quite a lot less. So I think one can look at the issue of contraception as something that actually could help in countries that have a very high pregnancy mortality rate. It could help with that also.
And in terms of making that clear or available to people working in medicine from that family planning clinic, a fertility clinic, or the community setting, is control of fertility and control of conception as valid or as professionalized a field as post-fertility research or the attempts to conceive? Is the planning against as well prepared as the planning for a family?
When you think about it, a family that is dealing with infertility, where you have in vitro fertilization and you have a number of techniques that can allow you to become pregnant, that's going to have much more visibility to individuals because it's very personal. Then the concept of preventing unwanted pregnancies or reducing population and so on, so that the science on in vitro fertilization has really been much more to the forefront. But I think this needs to change. When you think about the way that the world moves, short-term solutions always have more emphasis than long-term solutions. And for unwanted pregnancies, abortion is really an effective short-term solution. But when you get up to 10,000 feet and think about it, contraception is really something that's a long-term solution, and it's complicated, and it requires a strategy all of its own. And I believe, having looked at the what's been published recently in the media and reviewing the literature, I think this whole issue of contraception as a long-term strategy has really been neglected recently. And I think that we just need to think of all of the aspects of this that could make long-term contraception more appealable to individuals, more effective, and something that becomes an important goal long-term.
Yes, and I believe that leads to the speech that you also give on the 6 key steps for building a better system. If we could work through some of what those are and where the action currently is in terms of the US healthcare system, the US legal, political landscape, and what needs to change to move that towards something that has compassion and justice at its heart.
When we look at this, I think that we have to look at the principles rather than what's really happening in the US and elsewhere. In the US, these issues have been so controversial that one could think this is even a swamp. So we need to go above that and think of what is possible and what are some of the six steps that would be needed if we're going to be successful in this. So the first one is to change attitudes. And one attitude that needs to be changed is that we need to convince people that unwanted pregnancies are really not okay, This is something that's a failure. And women and men should know that they have the responsibility to prevent unwanted pregnancies. So the attitude should be not women have the ability to control their bodies and to have the choice to terminate a pregnancy. But the attitude should be that unwanted pregnancies are not all right. And as a couple or as women, we should really use the techniques that are available to reduce the number of unwanted pregnancies. The other issue about education is that we now have 9 billion people in the world. India has gone up to 1.4 billion, and we really need to think about long-term control of population. And one way to do this is to prevent unwanted pregnancies. And this is part of the overall education to change attitudes. Now, the next area has been pretty controversial, and that is that individuals need to understand about reproduction and about pregnancy and the issues about pregnancy if they're going to deal with this issue. So in the United States, many of the political attitudes have been, we really shouldn't touch this in high school or even earlier. But it's quite interesting that in the Netherlands, sex education is starting in primary school. It's not happening in the US. But I think that we really need to have effective educational programs in high school in the United States and elsewhere. And this really is to let people know what is available, what are the concepts underlying family planning and so on. And this would require a commitment really of governments and the educational system to have these programs put in place. Those are the first two, attitudes and education. The third point is governmental action. So what can governments do to help with the problem? Well, it's interesting. The United States has actually taken some action in this recently, and that's to make the morning after pill available. There are some colleges in the United States now that have free morning after pills available for the college students. So they don't need a prescription. There's no moral issues involved in this. They can do this. And governments can actually make the morning after pill available without prescriptions, can subsidize it so that it's at lower cost, and make it generally available. The government can also subsidize clinics that can provide this level of education. What I would see is that rather than having a family planning clinic, we would have clinics that are really designed for contraception. Now, that doesn't seem reasonable to a lot of people, but I'm an expert at this, and it's very hard for me to keep up with all of the various aspects of the risks and benefits of hormonal contraception or the other forms of contraception. I've got to look up things. And so having specialized clinics that deal with contraception, the individuals in those clinics would be able to know everything there is to know about the scientific aspects. And this is something that hasn't really been talked about. The next thing is targeted strategies. We can talk about contraception in the US, but what about Bangladesh? What about Kenya and countries that are underdeveloped or developing? And the issue there, I think, is that the forms of contraception will be very different in those areas. I go back to my mentor, Wayne Barden, who developed the contraceptive implant. And his whole perspective was that in underdeveloped countries, a woman's not going to go to the doctor periodically to get a birth control pill and have it followed for the side effects and so on. If one could put in a relatively inexpensive implant into the arm and it lasts 10 years, you have a way that is inexpensive and practical to reduce the chances of fertility in those individuals. And that's beginning to take off now globally, this concept. And these implants really are associated with very few side effects and complications. So it's something that really has worked. The other targeted strategy, which I really liked in concept, was that at one time I met the urologist who was the doctor for Chow Enlai in China. And he developed a form of tubal ligation in men that they could basically do in the subway station. It was a very interesting approach, and he began to popularize that. But his whole idea was that if you had a quick, inexpensive way of causing sterilization or prevention of pregnancy in men, this would be an appropriate way. Now, his technique never caught on, but the non-scalpel ligations certainly did. And I think he was a pioneer, visionary, thinking about how all this could happen. So then you have individuals who have very strict religious convictions and don't want to use hormonal contraception. The methods for natural family planning, my take on that is that they're probably effective in allowing a family not to have 4, 5, 6, 7, or 8 children, but not very effective in preventing individual pregnancies. There's an interesting story here that Henry Berger, who was asked by the World Health Organization to evaluate the scientific aspects of family planning, came up with this same concept. And after he and his family had had 6 children using the family planning method, they decided maybe they would try something else. So I thought that was an interesting insight into the issue. So those are some of the long-term strategies that need to be applied ultimately. I haven't gone over the 6, but I've gone over most of the critical ones. And I think that when one looks at that, one size does not fit all. We have many different ways to do this, and the reasons to use one versus another are complicated but realistic and should be understood and ultimately applied.
The first case that you made was in terms of attitudes towards pregnancy, the idea of shame and stigma around sex and pregnancy, especially unwanted pregnancies, are nothing new. And I wonder if there were maybe any ways to focus on building success stories of deferred parenthood rather than necessarily using it as a rod to beat people with.
Yeah, this is a difficult question. I think that the major focus on this issue has really been to try to reduce world population. And for instance, countries like Kenya, where 30 years ago the average number of children in a family was 6 or 7, it's now down to 2 or 3. And this has really been accomplished primarily by education. The other approach, of course, is the one taken by China, which was very, very constrictive, that you could only have one child. And obviously, that's not something that we want to encourage. So I think that for 2 reasons. One, the overall issue of family reducing population. But the other one, which is really important, is that families that really can't afford to effectively take care of 3, 4, 5, 6, and 7 children, by using contraception to limit family size, the 2 children that you do have, one has much more resources to provide appropriate education, appropriate nutrition, appropriate clothing, and upbringing, and so on. So all of these issues focus on the need ultimately to reduce family size. That doesn't, if I can go on, that doesn't really address the issue of induced abortion, where you're reducing family size, and contraception. And I think this is an issue that we need to grapple with, but it's not a new issue. I found out in my reading that Soranus, who was the preeminent gynecologist in Rome in 110 AD, basically said, it's much better to prevent a pregnancy to abort. I was amazed at that because it was exactly the thinking of today. And of course, Hillary Clinton said the same thing, that if we effectively use contraception, we aren't going to have to be concerned to such an extent about abortion because it will be rare. So this again is I think, the educational thinking that we need to emphasize at this point, and really hasn't.
Well, there's 2 points on education that I think are worth bringing up, and one's on the domestic scene for you, and one's on a more global level. Let's start off with, in the US at the moment, there has been, in the last 5-10 years, an intensified backlash against sex education. what there is compared to, like you raised in the Dutch example, of getting it in primary education. I know that when I was growing up, we had sex classes in, I think it was year 4. It's about 9 or 10. They just went through the anatomical diagram of ovaries, ovum, cervix, like basically flip chart. This is like the mechanics of where that all fits together. But with this backlash against sex ed as kind of the one arm of a, to put it in politely, a culture war that is being raised against liberal ideas and anti-LGBTQ campaigns, is that something that challenges the idea of a national rollout of these kind of education programs, or is it something that would require a more targeted approach to even, home-based interventions or self-led provisions if schools are made unable to provide the kind of education at that age?
You've asked me a question that is impossible to answer, but let me give you my take on it.
I think I might have asked you 7 questions there. I do apologize.
No. My take on it is that people have a wide range of opinions and a wide range of upbringings and religious convictions. And that when we look about what has happened in the world over a long period of time, if one looks at the science and one looks at the principles behind this, that in time, these opinions can change. Now, in the United States, it's quite interesting that, of course, we talk about the red states and the blue states, the Republicans and the Democrats, but the red states are very much against sex education in schools. The blue states have really welcomed it. So it says that even in our country, things are done differently. So how do we get around this? I think, again, the individuals that are interested in this need to provide the science. They need to speak about this and write about this using the principles and trying to get around the individual biases. But this is a challenge, and it's going to take quite a while, I think. But it is evolving in the U.S., clearly has evolved in the Netherlands, and I think more so in the European Union than in the U.S.
And then the next question I had to address kind of the education, and especially the global education points that you've raised, is when discussing the idea of there being efforts towards global population control and, managing a global population upwards of 9 billion. So far, a lot of the interventions and educational policies that you've raised have been, frankly, over there. They have been reducing the population for these booming populations in Bangladesh, Kenya, kind of Southeast Asian, North Saharan Africa. And with those booming populations and that increasing birth rate, I think it's worth taking the time to unpick that if there is an increased birth rate, is that due to an also increased child mortality rate, or if there is improved healthcare provisions so that there are more children being born who are then living longer? Are we just waiting to see the generational effect of, I'm not terrified that all my children are going to die at the age of 3, so I won't have 7 or 8 children. So then that overall population boom will tail off maybe in 20, 30 years. Is that worth, considering or addressing?
So all of those issues are clearly important issues. But I think what we've lost sight of is that the birth rate per country is inversely proportional to income. So high income countries have low birth rates. Italy, I think, the lowest probably in the world, whereas low income countries have high birth rates. And I think then probably an important issue is this whole idea of trying to increase the overall level of income in various countries. And with this, a direct effect, I think, will probably be to reduce birth rate. But your concept of having more children because of mortality, high mortality, that was a concept that was highly prevalent in developed countries before the era of antibiotics and public health and so on. But those concepts have still been highly prevalent in countries like Bangladesh or India or countries that are undeveloped. So I think that when I talk about a multi-pronged approach and strategy, we really get into an area which is complex and requires multiple strategies, not just one.
And then to raise the points that you made of government action and targeting strategies, are there any ways to resolve the idea of doing big, broad, sweeping national or even international efforts, like you say, on either raising overall economic stability and income, or educational campaigns for, if there is, I don't know, that, the technology of 10 years in the future of having a safe, reliable contraceptive pill for men comes through to make that as widely available as possible on an international level, is there, I suppose, a tension, or is there any way of getting action on huge sweeping changes, or is the focus better spent on those targeted strategies? Is a way of doing both at the same time? Is there a provision to do both at the same time, the political will or the funding to make that all at once?
So really, you're raising the question of priorities. Which of these areas are the most important? Now, I'm a practicing physician. I take care of very complicated patients that have endocrine problems, and I recognize that my colleagues who are not endocrinologists throw up their hands about some of the things that I'm an expert at. And so I think one of the highest priorities probably would be government-sponsored contraceptive clinics, particularly in low-income countries, so that you would have a cadre of highly trained healthcare providers that knew all of the aspects of contraception. And then any family that's considering pregnancy would have a place to go where they could understand and be taught all of the options that were available to them. Now, that would require government action. It would require the decision that these are important. And I would put that really highest on my level of priority. And that would be something that could be done fairly sweepingly with government support.
Do you think there is any likelihood of that coming around on the US domestic scene, or if there have been, the most advanced, the most liberal attitudes towards sex education like you see in Europe, do you think they might be the first to do that?
My sense is in the US, we've got to resolve the issue about induced abortion before we can start focusing on this. I'm going to change the subject just a little bit, but one of the other things that I wanted to say, and that is I tried to look historically of what was thought about induced abortion. And what I came up with is that we will never resolve what the morality is of induced abortion. Why did I think this? Well, I thought this because over the centuries, in Rome, for instance, in 110 AD, or even 300 or 400 years later, even the Catholic Church said that there were unformed fetuses. And what they meant by that was a fetus that was living but was not a human being, and that it would be not sinful or immoral to deal with termination of a unformed fetus that was not yet a human. So then I began to look and try to figure out currently what is the thinking about that. Well, the Catholic Church says that it's conception, at the time of conception. Others say it's the time that there's a heartbeat. Others say that it's the time of quickening. And some of the religions say it's the time that the baby comes out of the womb. Our Supreme Court said that you can't really, this was Roe versus Wade, you really can't tell, and it's a spectrum such that it's much more likely that you have a fetus that's a human being in the third trimester than in the first trimester. So right now in the U.S., there's all the debate about this. And when you look at the history and how this has been looked at over the years, I don't think it will ever be resolved. And I don't think so because there's no way really to scientifically or objectively knowing when a fetus ultimately develops human characteristics in such a sense that induced abortion would be immoral. And I think that's why also in my reading about this and thinking about it recently, I've really made my emphasis much more on prevention than on the controversial moral aspects. And I think most of what I've shared with you in my thoughts are not based on morality, but are really based on practical scientific issues. We have to prioritize, and that's always the most difficult thing to do. I believe that starting with educating healthcare providers about these issues is probably a place to start. The providers then can begin educating their highly influential patients to begin to act to convince politicians about this. Those of us who have taken care of patients over a long period of time know that if you've established a rapport, mutual trust with a patient, you can really influence someone to take action. And I've seen that in my own career, and that's why I'm thinking starting with physician education would be a good start. Then educating the general public about this is important, and always this is the thought leaders primarily that we want to influence. This again might be done through the physicians. Only in that way will the politicians ultimately take action, because they generally take action when there's a consensus or a groundswell of attitudes among their constituents to move forward. So again, a very complicated issue. I'm a little bit biased because I'm a physician and I take care of patients. I have over a long period of time, and I know about the rapport that one can establish. And this is a scientific issue because of all of the complexities of the issues of contraception. So I see this starting really on a medical front, secondarily with patients who are opinion leaders, and then thirdly, politicians, and finally government.